All right. It is 2 minutes after the hour, and we're going to kick this online live roundtable off. Hello, everyone. My name is Barry Olsen, and I am a language and technology consultant as well as an interpreter with a few years of experience under my belt. It is a pleasure to be with you here today. So, welcome to the first roundtable in our series dedicated to language access in various industries. The organizing force behind these roundtables is Effectif, a technology interpretation and localization company. So a big shout out to them for making this space available today. Now, today we're going to focus on healthcare, how things there have changed after the pandemic and the role of technology, including remote interpreting technology. You know, what this technology, what the role of it is and in this landscape. So we'll hear from some experienced practitioners in the field of language access. I'm going to introduce them in just a moment. And we're going to learn about their perspectives and the best practices that they have put in place. Because running a successful language access program can be extremely challenging. So I'm pretty sure you're going to want to learn a lot today from the people that have managed to be successful in building a program and executing it. So let me go ahead and introduce today's speakers. First, we have Ligia Gutierrez, who is from the Ochsner Health Program, and she is the Language Services Program Coordinator. Catherine, welcome, or excuse me, Ligia, good to have you with us today. Second, we have Tina Tolson, who is the Senior Director of Operations at Johns Hopkins Medicine. And to round out our panel today, we have Catherine Adames, who is the Director of Operations at Effectif. So welcome to each of you. And as we get started, what I would like to do is ask you if you could give us a quick introduction to how you started working in language access and how did your programs that you were in charge of, how did they start? So let's go ahead and start with you, Tina, and then we'll go to Ligia. Tina, welcome.
Great, thank you. Thanks for that introduction and for having me. I started within language services at Johns Hopkins about 7 years ago, but my roots in language services actually stem back to my nursing school entry letter. And actually before that, when I minored in Spanish, and I've always had a passion for serving those that speak another language and helping them communicate, especially for healthcare conversations. So I got started in language services a long time ago, and even in the emergency department as my first nursing role, have always been helping to try to improve the tools and the resources that are available to our staff and to our patients to promote that. How I got started in the program that I'm in right now, in the department that I'm in about 7 years ago, is I feel like I've come full circle because it's an interesting story that kind of brought me back to my roots. But the language services program at Hopkins existed well before me joining the language services department, and has actually started about 25 years ago as part of Hopkins International. And it was intended to more serve the community, the local community within the Baltimore area, and clearly that volume of patients that have limited English proficiency has grown in those 25 years. And so the tides kind of shifted as far as the volumes, and it became apparent that there were a lot more language needs served beyond just those international patients. In the program, at the time that I had gotten involved, there were some gaps that were identified across the system, and Hopkins International served several of the organizations within Hopkins, but at the same time that Hopkins International and the language services program was growing, so was Hopkins, and there were several entities that had joined the Hopkins team along the way, and they had their own language services efforts and programs going on. So at the time that I joined about 7 years ago, again, those gaps became apparent, and I was asked to lead an effort to standardize our approach across the system, which we have done, and I'll talk to you more about that centralization process along the way. But that's really how our program started and how I became involved with that many years ago.
Excellent, Tina. Thank you. Ligia, go ahead.
Thank you. Well, I myself have not been in language services that long. I started as a PRN interpreter in 2017 here at Auctioner. It was actually my first interpreter job. And then in 2018, we had a new director of international services, and she asked me to help her create an official language services program and centralize interpreter services throughout the whole system so that everybody could have the same policies and procedures. And so I became her right-hand man, and we worked for 2 years creating this program, which is the one that we have today.
Yeah, it's always fascinating to see how people come into language access from a lot of different places. So I need to ask you, Catherine, as well. How did you get into language access?
Well, it's been long. I've been in the industry for about 17 years now. I started as a Spanish interpreter. I think it's my very favorite career. Very humbled and very happy to be an interpreter. Then I became a supervisor, and I started to grow thereafter, creating opportunities for other interpreters with training, and then also working with customers and providing the services that they so urgently needed.
Awesome.
And here I am. Yep.
Well, we've got a lot of expertise in this panel today. So I'm going to get into this next question, and let's get right down to, something that was in the title, and that is, how have your language access programs changed after the pandemic? And specifically, what's happened with that mix of VRIOPI or on-site, right? We went through this whole situation where the pandemic hit and everything went online. And then we started to pull back. People wanted to have those face-to-face interactions, et cetera. But nevertheless, I think we've all seen that remote interpreting isn't going anywhere. But how is the mix, and how has it changed your programs? So why don't we go ahead? We'll go back to Tina. How has it changed your program? And then Ligia, we'd love to hear from you.
Yeah, absolutely. Technology completely changed over the course of the pandemic, and really in the sense that it increased access. Having the means of providing the interpretation through the various tools and resources that were deployed during the pandemic really helped shift the tides, and in many ways increased the amount of access that was available to people, because relying on in-person interpreters, which many of our organizations did, or at least several of them within the Hopkins system, were dependent on in-person, and it actually kind of created delays sometimes and barriers, right? Because you can't have an in-person interpreter for every language. You're not having an in-person interpreter for every encounter. So it really helped to by deploying the amount of devices that we deployed during the pandemic, it completely reversed the volumes as far as the amount of over the phone and video remote was the vast majority of interpretation that was provided, as opposed to now only about 10% being in person across our system. And we're doing hundreds of thousands of encounters a year of interpretation. But it really helped to improve the amount of access. And telemedicine was the other thing that really exponentially increased during the pandemic, whereas pre-pandemic, it was something it was on the radar and we were working towards it. But during the pandemic, it was okay, it's here. We have to figure out how we're doing this. And we did. And we really increased the amount of services that we were providing during that time from our own staff. We figured out a way to have our own staff be able to be connected to telemedicine encounters. And we also partnered with our other agencies and vendors to increase that as well, and to, again, increase the access. So we have more than doubled our amount of interpretation that we have provided since the beginning of the pandemic.
Wow,
and
that's pretty significant.
It's significant, and vastly due to the amount and the access to the technology. We deployed bedside phones to all of the clinical staff, and it was really a game changer because they had an interpreter in the palm of their hands, literally. And so they were calling on interpreters much more readily when they needed one, which was what we were hoping for.
Yeah, ease of access really can make a big difference, can it?
Absolutely.
Excellent, Tina. I've got a lot of follow-up questions, but I'm going to hold off on them because, Ligia, I want to hear from you.
I'm on the same boat as Tina. I do agree with her. Technology has completely changed the way that we use language access. I think that COVID came to help us have more respect for the remote interpreters. Unfortunately, there's always been this stigma that it's, in person is way better than everybody else because you don't know, I don't know, the training or whatever. But COVID came to basically open our eyes and be like, all right, guys, you have to do this. Remote interpreters are here. They are the solution to the problem. Before the pandemic, OPI did most of our encounters. We had 60% of our encounters were OPI and only 31 was VRI. Since the pandemic came, the clinics closed, virtual visits started to be something that we were actually using. We had to, we had to evolve and change our ways of doing things. We also had to help our patients evolve because many of our limited English proficient patients or deaf and hard of hearing patients, they didn't know how to use maybe not the deaf and hard of hearing, but definitely the limited English proficient. They didn't know how to use the MyChart application for their appointments and to be able to do virtual visits. So we actually had our interpreters call our patients. We had a report pulled from Epic of limited English proficient patients who did not have MyChart, and we had our interpreters call the patients, help them connect to MyChart, download the application, make their profiles, and then we coordinate the virtual visits. We have the interpreters call the patients beforehand. We have them make sure that the patient knows how to do their e-pre-check, et cetera, et cetera, et cetera, et cetera. And then during the pandemic, we had to change our video remote vendor because we found a vendor that was able to include their services within our Epic MyChart visits. And they were also able to include it within our telemedicine platform.
Yeah.
So like Tina says, our encounters have increased exponentially. We went from 200 VRI devices to over 2,000. All of our hospital floors have VRI devices. The hospitals that have bedside tablets, the tablets have the VRI device. So we have made it accessible for everybody to be able to use VRI. And so today, 62% of our encounters are VRI and only 32% are OPI. So
Wow.
it completely switched.
Yeah. So there was a real flip that came. And I think there are a couple of things, if I can just jump in as I've been listening to this, a couple of observations that I think are important. One, the way that this has been able to expand access to healthcare. The other is that, interestingly, Ligia, as you said, you had your interpreters out calling. So you can see how the technology has actually perhaps shifted just a little bit what the job description is, right? They're still interpreting, but it's almost like there's an advocacy role that they're taking on, or an administrative role where they've got to be able to help people make that transition to the technology platforms so that they can then access healthcare, right? And I think that that's an important trend to watch as we look at the inclusion of new technologies, especially right with everybody talking about AI, that it is starting to shift job descriptions and in some cases broadening. And so we can't think about just having people do this one thing, because that one thing is going to adapt and in some cases may go away. Right. So fascinating. But Catherine, what have you seen on your side? Right. You're on the supply side. Does your experience match up with what you've heard from Tina and from Ligia?
It definitely does. And I want to share, can you guys see my screen?
Yes.
Great. I wanted to share this graphic with you. It's taken from NIMSI. And I would need to say that our experience has been mostly the same. But going from what Ligia was saying, I think that the pandemic was a booster on the goal that of communication that us LSPs have. And it also allowed language access to demonstrate its importance within, our ecosystem, and especially under crisis management situations. I couldn't think before this situation of an interpreter actually needing to call a patient and being that first gateway of communication, patient and provider. So as you see here in the image taken again from NIPSI, it shows that post-pandemic on-site services have decreased compared to what it was in the pre-pandemic era. In our experience, I can say that remote interpreting is steadily gaining ground, and we can expect this market share to advance significantly. So I am right there with Ligia, and the same with Tina. And especially because it has proven to be cost effective, and clients are now understanding that they're keeping the same quality. Clients are asking more questions about training that remote interpreters are getting. They're more aware of the companies out there providing training and the vocabulary that these interpreters manage. In addition to this, I would say that also customers are more aware of the different type of interpreting services that there are. Before, it was just on-site or just don't send me anyone, and now it's, okay, maybe I can have a VRI interpreter instead. I would say they're helping us a lot in this area.
Mm-hmm. Excellent. You know, as we look at this graph here, I mean, it's very clear that the remote services are definitely continuing to advance while we're seeing fewer on-site assignments. But I wonder to what extent, and this is a question I think for Tina and Ligia, if you have any observations on it, to what extent do you see VRI actually beginning to replace the use of over-the-phone interpreting? You know, Ligia, you mentioned that you've had all of these VRI devices that are now available throughout the system. Is that starting to have an effect on the choice between using audio only with OPI and VRI?
Sorry. Yes, definitely. The fact that they have the iPads and the tablets at the point of their fingertips, it helps a lot. We also were able to include our VRI service in some of the Spectral Links, the phones that the nurses have. So that yeah, definitely.
Okay. And one other observation I had, I just remembered as you were talking, is the importance of integration, right? Both of you mentioned it's like, look, when we've got to pull all these things together, we had to switch vendors because we found a vendor that could integrate with this system. They could integrate with this other system. And that has so much to do with ease of use and the ability to be able to offer a service within an existing system at a hospital or, you know, a healthcare center, if you will. Tina, is there anything else that you wanted to add? If there is, great. And I'm going to also piggyback with one more question for both of you. Now that you're seeing this growth, what are the most frequent use cases? And, you know, is there a use case out there that you're like, wow, never expected that one, but here it is?
Mm-hmm. You know, I would say, again, I think it goes back to that ease of use. And we actually have seen a growth in over the phone and VRI, but actually more so over the phone. So despite the fact that we have all of these, you know, video capabilities out there, they're small on the phones, right? It depends on the tool that they're using, right? And we have a lot of iPads around, but at the same time, they have audio and video access on those tablets, and we have a lot more probably phones than we even have the iPads. And so because of the phone, they can do video and audio on the phone, but it's probably, you know, it's a small screen, right, on the phone. So the volume of over the phone, the audio connection without video has actually increased as well. So even more so than the video. And so
okay,
just to point that out there again, it depends on that ease of access and how they're most readily, they have the option for both, but why they're choosing audio versus, you know, video may depend on the tool that they're using.
Yeah, that would be an interesting survey to do to see how they're going. And the technology nerd in me is coming out. But and Ligia, what about you?
Well, VRI is currently our primary source of interpreting. And so there's not really, I don't know if anything what surprises me in the use of VRI, and they use it for basically everything. I think the most that it is used for is primary care, because we are a little selective about sending in-person interpreters because they are limited to certain situations, and primary care tends to be the one where, unless it's something that is very complicated or very traumatic, It's a 15-minute appointment. The doctor checks you up real quick and then you're out the door.
Yeah.
So primary care, I would say therapy and wellness is another big one sometimes, just because it's so difficult to get interpreters out to them. But yeah, VRI it's our big one. We have seen an increase, as just piggybacking on what Tina said, on encounters in general. I think, if I'm not mistaken, my numbers are there's about a 40% increase from when the pandemic started and encounters in general. But VRI is definitely the one that they seem to choose more than OPI.
Okay. Now, there's a question that's coming, and I think it's a really fair one. It's like, what about ASL? How are you approaching ASL? Do you approach it in the same way that you do with the spoken language and the technology? Do you have a different technology that you're using for ASL?
We actually have, our language program is split in two. So we have the limited English proficient, and then we have the ASL program. We have a ASL coordinator, and she looks at Epic reports, and she is able to see the appointments that the patients have. And for the most part, we prefer in-person interpreters. We use a vendor who will, we can send a request over to for in-person interpreters. And then if for whatever reason there's not an interpreter available or whatever, we can't have the in-person, then we will use the VRI. And in some cases, depending on who the patient is, because we know some patients prefer in-person, then VRI will call the patient and be like, hey, I'm so sorry, we've tried to get you an in-person interpreter, we weren't able to do that for you this time, but we will try to do better next time.
Yeah. And so, yeah, go ahead, Tina.
Oh, I was just going to comment about the ASL, because it definitely does require a different take on evaluating the needs, and the ASL needs are all part of our language services program, which was not always the case in the history of language access at Hopkins, but it has rolled up all under one, and the needs of the those who have who are deaf and hard of hearing or hard of hearing are different in the sense that it's not a one size fits all, right? You can't just utilize, say, okay, let's use VRI because it works for everybody, or let's use using audio isn't an option. So there's less options. And again, because it's not a one size fits all, it does require more analysis of what those individualized patient needs are and how to meet them. They may need a tactile interpreter. They might need cart services. There's a lot of other things. So we're doing a lot of work around analyzing those and assessing those patient needs and educating clinical staff who may come with the mindset that, oh, this person's deaf, they just need a sign language interpreter, and I'm just going to use the VRI. Whereas meanwhile, the patient may be low vision and they can't utilize the VRI. So it really does require a lot more thought up front, and that proactive approach, which we're working with our clinical teams to take into consideration, and trying to provide them some tools and resources to better manage that, so that it can and some training around that so that it can be better managed.
So it really sounds like, patients' needs and preferences need to be a significant part of the equation. Whereas, a lot of times when you look at this and you look at the stats, you just say, oh yeah, look at this is growing. And here we're able to become, we've increased our number of encounters and we've become much more efficient. But at the same time, that's not the whole story. Although it can be important, there's so much more that goes into this to ensure that people are getting the standard of care that they deserve, right? So, all right, we are through first round one. We're a couple minutes behind, but that's okay. Stefan, I don't know if you can go ahead and publish the results of that poll. I think it would be great for us to be able to see who we have on the call today. Thanks. That's up now. Got lots of language access coordinators. We've got a lot of freelance interpreters that are connecting. We've got some healthcare execs as well, directors of diversity, equity, and inclusion, ADA compliance, great language tech specialists as well. And we've got others that don't fit any of those categories. This is actually a really good cross-section. And so very happy to have you here. Thanks for putting that up. We'll go ahead and close it out, and we're moving on to round two. So here we go. Ligia, this one's for you. You helped build the language access program at Ochsner Health from the ground up, if I'm not mistaken. What was that process like? And what would you say are some of the must-haves for a successful program, in particular, but not exclusively from a technological standpoint?
I wouldn't say we build a program from the ground up, just because Oxnard has had interpreters from the beginning over 75 years ago with their international program.
Okay.
As the times changed and there were more local patients, and interpreters shifted from only helping international patients to going to local appointments. I'm sorry. We didn't have an official language services program, though. It was just interpreter services. That's what they called it. So this is where my leader and I came in. So the first thing that we did was we started studying regulations and laws and federal regulations and things like that. We did some benchmarking with other hospital systems, which helped us a lot. A lot of the things in our language services program were created an image of the other programs that we benchmarked with. We created the interpreter request form. We made an electronic interpreter request form. At the time, we were still working with fax and paper. So we made the electronic interpreter request form. We were able to make a scheduling system for our interpreters. It used to be that unless we had the fax paper where we were going, the clinics would just have to call last minute and be like, hey, I need an interpreter now. And the coordinator would have to look for the interpreter and be like, hey, I need you to go here. I need you to go there. It was a lot of running around because we didn't have a set schedule.
Mm-hmm.
We were able to complete an in-house call center for in-house interpreters to be able to answer the phones when they're not on site. And in our call center, we have the system in a way that if our interpreters are out, it goes automatically to a vendor, so that way we don't lose any calls.
Mm-hmm.
We created a language services task force with multi-departmental stakeholders within our organization, and this task force was the foundation with which we developed the program. And then from a technological standpoint, I think one of the most important things is having a good internet network. You would think that that's not a big deal, but it is. Your VRI system needs you to have a good
Ask any interpreter
system.
how important internet is.
Yes.
I'll tell you.
And then just making sure that you incorporate an electronic interpreter request method. This is very helpful when you want to collect data for data collection on the usage on, I can get percentages of cancellations, last minute cancellations, no-shows, et cetera, et cetera. So those for me are very, very, very essential, because without the data tracking, there's no way of us knowing how we're actually doing in our systems.
Mhm.
Yeah. So just quickly to kind of sum it up, one, you've got to have buy-in across the
Yes.
ecosystem, right? From a lot of different places. You've also got to be able to have a way to report data, to be able to produce reports and show what's going on. There's a lot of really good stuff in there, but I can see very clearly that you've had some significant efficiency gains because of the efforts that you've undertaken. So I'm gonna jump over now, and I want to ask Tina. You referred to at the beginning about a centralization process that's going on, because Johns Hopkins Medicine is a pretty big network, right? And you acquired some hospitals and you had these different programs, trying to bring that all under one tent and making sure everybody can, interact appropriately. How did you do it? Or how are you trying to do it? Maybe I should say.
We're doing it. I mean, we did it during the pandemic. And the pandemic was a blessing and a curse in many ways. But really, what really helped to get the buy-in initially was the having a burning platform. And fortunately or unfortunately, sometimes the burning platform are external forces, like legal or regulatory folks coming in and saying, hey, you could be doing a better job of this. And so that it helps to have that as leverage, though, especially when you're communicating with executives and senior leaders, like, okay, this is not just like a nice to have, this is like a must do. We have to do this. And so utilizing that to the advantage and establishing the program and the details that you put forth. We actually developed a business plan, because the other essential piece of things is how we funded. And,
Mhm.
you know, this is like, okay, it's yes, we have to do it. And sometimes it is just what it is. And you put the cost up front. But at the same time, like if there's, you know, the financial acumen and just awareness around it also helps when you do a business plan. Like, how are you going to ensure that this is managed in a way that is cost effective, right? And it's not just like throwing resources at something to make it work. So that is a critical element from my perspective, from the Hopkins perspective. I think that that's what got us the leadership support and the buy-in, that yes, we had the burning platform and we had a plan for how we were going to do it. That plan was catapulted by the pandemic. And that's why I say the pandemic was a blessing and a curse, because we had planned to increase access to the technology and also balance that with in-person interpretation and come up with a whole model for that. But the pandemic kind of level set the whole playing field, because we had entities all across the enterprise that were functioning in different ways. Some were very dependent on in-person interpretation. Some were adamant that they would not use in-person interpreters. They would only use over the phone. They didn't even have VRI. So we had literally examples all around the system of varying practices. We were not working like one organization. We did not have a standard approach. And it was, you know, no one size fits all in this. So it wasn't that one thing was right or wrong. It was just that we didn't have like the Hopkins way of driving, you know, appropriate language access for our patients and communities. So patients may have different experiences at different entities, depending on which Hopkins entity they went with. And so that was another driving force where we could speak to that and say, you know, we as Hopkins, we want to bring in these best practices. Tell us about what you're doing that's working well. Tell us about what you're doing that's not working well. How can we help you? And really collaborating with all of our entities and their leaders to, you know, provide that engagement and provide that driving us forward to create aligned standards. So we did outline an aligned policy, but it was with going to assessing the gaps at each of those entities and bringing those best practices, which is still a work in progress, and we're in a continuous state of improvement. But those are critical, I think.
Completely, yes, definitely. So, man, I have a feeling that there are a lot of people that are taking feverish notes. I can't hear them because obviously they're somewhere out there in cyberspace. But a lot of good things coming out here. I have a question for both Tina and Ligia, and I'm going to give you a chance to think about this, because I've got a question also for Catherine. My question is, okay, how do you balance your workload between staff and third-party interpreters? So think about that for a moment. Catherine, I want to go to you. We've got a lot of interpreters that are on this webinar today, right? And particularly freelance interpreters. And freelance interpreters are like, okay, how do I gain clients? How do I do this? How do I get their attention? So, I mean, what advice would you be able to give as someone who's been working and hiring, you know, freelance interpreters for a long time? What advice do you have for them if they want to begin to work in this space, and what do they need so that they're really going to stand out?
Well, being on site or VRI or OPI interpreter, the first thing that I would need to let them know is to go by the code of ethics. This is our little Bible, and I am speaking as an interpreter. And also they need to monitor how our industry is going. Where is it going? How is on site right now? How is VRI right now? How is the OPI looking right now, to see where they would want to maybe apply for a job or captivate a customer. Also, it's important for interpreters to learn technology, to see what technology is out there, what the customers are using, what companies like ourselves, LSPs, are using in order to make communication easier for customers. They need to make sure they have the adequate equipment. If you're working VRI, if you're working OPI. And I think Ligia mentioned internet connection. And for us interpreters, it is the most important. Have a good internet connection and have a noise canceling headset. I was actually speaking to some interpreter friends, and I was discussing some things about this roundtable, and they had the same question. My advice would always be code of ethics, trust your training. Make sure that you don't stop only at the training that your company, whichever company you have worked with, has provided to you. There are great trainings out there. Our industry is growing every day, and there are different areas in which interpretation is needed. Be confident in what you know. Make sure that you act professional. You render all the information that is being given. Go by the code of ethics. That is absolutely your Bible. Act professional anywhere that you go. If you're going on site, make sure that you're dressed accordingly. Have a uniform. I always think about having a uniform in the sense of nice shoes, look, professional, speak correctly, try to speak slowly when you're interpreting, or at a good pace, not slowly because then you might get in trouble, but at a good pace, and stay complete, stay accurate at all times.
Excellent. All right. So we're going to jump back to that question. I've given you a little bit of think time. Who wants to answer first? I don't know.
Yeah, I
Licia,
can
go
go.
ahead.
Yeah, I can go. So we have staff interpreters in Spanish, Arabic, Hebrew, and Vietnamese. It sounds like a lot, but we honestly don't have that many interpreters. I wish we did. We use our staff interpreters in appointments that are within the region where we are located. We're in New Orleans, but our health system is very large. It's the largest health system in Louisiana, so we're all over the place. The agency interpreters are used in appointments in regions where we are not located, or if it's a language that we don't have staff interpreters in. As I said, we're pretty selective about the types of appointment where we send the in-person, because we're so limited in our in-person interpreter pool. So that's how we balance it.
Yeah. Sounds like having a really trusted partner is important.
Yes, very
Yeah.
very important.
It very much is. So for us, we primarily utilize agency interpreting right now. We do have a team of staff interpreters that are primarily staffed at our campuses in Baltimore, but we are in the process. Again, we centralized amidst the pandemic, and so we have really not had a full baseline year, except for FY23 was pretty close, except for those few blips of surges, right? COVID surges where we kind of pulled back, but we're in the process of evaluating our system needs and in alignment with prioritization guidelines and deployment guidelines so that we can strategically optimize our mix of staff interpreters, our own hired staff interpreters, in addition to agency interpreters. We're never going to be able to hire enough staff in the mix of staff that we need for the languages, right? So we'll always have some degree of third-party support, and especially for in-person, but also for over the phone, video, remote. But we're working to evaluate that and to I don't want to say level set that mix, but to balance that mix a little bit more as we move forward, and to again align the standards across the system, because we have certain hospitals that have staff interpreters where we have very large volumes of Spanish speaking patients at 2 of our campuses, and we can count on every day they're going to be there. But in another hospital, they may have more sign language patients on a daily basis, or Korean, or Haitian Creole. And so how do we balance that we're those staffing needs and minimize the amount of third-party dependence that we have, and also hire our own group of interpreters to be able to
I think
do
it goes
that.
back to the importance of reporting and having access to the data to be able to really figure it all out. And that's one of the things that didn't exist previously, right?
Exactly.
And interpreters were very used to, it's like, okay, I have this personal relationship. They're going to call me when they need me, and I'll see if I can fit them into my appointment book. But we're at volume levels at this point where that just can't work if we're going to be able to provide the service, right?
Absolutely. And if you're, in the time and day of, financial kind of scrutiny, right, of things, there's things that we have to do, but if we do need to be mindful that that we're utilizing the data to show and tell the story about what we need and why we need it, right?
Yeah.
It's not just because this doctor wants to have in-person interpreters, so we're just going to do that. Like, we really need to be able to paint that picture and explain the quality of care that's provided by in-person interpreters, and why we need to prioritize them for certain select encounters, and the minimizing the risk in those encounters. And that, I think, is going to speak more to the executives that are critical in supporting these positions and these departments and these efforts across the nation, really.
Yeah, for sure. Because it's definitely something that is not going away.
It's growing
at all. So, all right. We are now going to move on to round 3, which is the speed round. But before we start the speed round, I just want to say to all those who are in attendance, there is a Q&A button in the lower part of your screen. If you have questions, please submit them now, because we are going to move on and have them answer some questions from you that are with us today. So if you do have questions, now's the time to write those, and I will go in and pick and choose those that I think are going to be most apropos. So with that, speed round, here we go. I want you to try and keep these answers as concise as possible. But if there's more information that you need to get out, don't hesitate to take a minute or so. All right, here we go. First one. What is one thing you wish you had known when starting your language access programs that you didn't and you know now?
Me to start?
Yes.
I wish that I had known how different each of our Hopkins entities was. I really was naive to that and thought, oh, we're part of Hopkins and everybody kind of works the same. And I was naive in thinking that. And so that was one thing that I wished I had known. Like I assumed that they had the same policies and processes, but I had to create all of those. So yeah, that was one thing.
All right, Ligia.
For me, it's how complex this language services actually is. Like I said, I started as an interpreter and I had no idea what I was getting into when I started on this journey, and it's just so complex. It's not just, you're a bilingual, you can be an interpreter, or oh, this patient came here, let's get him an interpreter. It's not that easy. It's just there's so much that goes on in the back end that most people don't realize how difficult it can be and how much work it is for us to be able to manage these programs.
Yeah, for sure. Next question. Post-pandemic, what has been the most frequent use case for remote interpreting in your program? Now you have to go into that data you've been collecting.
For us, it's just VRI has just boomed since the pandemic. We have used it for almost everything and anything that we can't have the in-person go to. So I don't know if there's anything that's most case. I mean, like I said, I would say probably primary care and therapy and wellness, just because we have to limit so much. We'll send in person to like the first therapy or wellness appointment, and depending on what type of therapy it is, for the established patient, we'll be like, please use the video remote interpreter or the phone, whatever is easier for them, just because it's so complex on getting an in-person there.
I would say those brief encounters where they may be unpredictable or just a brief 15-minute visit or conversation, that arranging an in-person interpreter for those, especially for a language that may not be as accessible, is it's much more conducive to doing that through the phone or the video.
Okay, great. Next question. What is the ratio between scheduled and on demand?
Well, on demand for us is 80% and 20 pre-scheduled. Okay. Was this question for me?
No, it's for everybody. Anybody who wants to answer it. But you definitely got the points on that one. If I had a bell, I'd be ringing it.
Ours is about the same. It's about 80% on demand because it's the phone and video.
Wow.
That's That's what people want things now. Like it's like the work that it takes to pre-schedule something is like work. So people don't want to have to do that.
But
call it up.
It's also important to, and I'm sorry, Ligia, it's also important to know that there are certain languages that need to be pre-scheduled. They're not, the interpreters are mostly busy for very rare languages. And so our advice to customers is always, if you know it's a language of lesser diffusion, it's best if you pre-schedule that.
Mm-hmm.
Anything you'd add, Ligia? Same, different?
The same difference. I mean, compared to the amount of encounters that we have, we only receive between 200 to 300 interpreter requests via our request form. So yeah, it would have to be between 80 to 90%.
Sounds like the Pareto principle is in play here, where you've got the 80-20 split. Well, great. We're going to close out that speed round, and we've got some questions from those that are in attendance. And so this actually has to do with what I was going to call the $1 million question. But Jim Busby has asked, what is your thinking around automatic speech recognition that is emerging and speech-to-speech translation? So it's the AI question, right? Are you exploring possible use of AI technologies, with speech-to-text or speech-to-speech? And if you are, can you tell us anything about it?
It's coming. Go ahead. Yeah.
Well, we're not officially exploring it, I don't think. I do believe that we're going to have to work in conjunction with AI to help expand the services and expand access to our patients. But I also believe that AI cannot replace a translator or an interpreter, just because there's just so many things in language that AI may not be able to get to. I mean, we were talking the other day, and just in my office, we have somebody from Colombia, somebody from Venezuela, I'm from Nicaragua, somebody from Honduras, our manager's from Spain, we have somebody else from Peru. So, and we say things in so many different ways. We always have discussions of how the differences in the ways that we speak, that I honestly don't think that AI can replace an interpreter, but I do think that we can work with AI to improve our access.
Yeah. Well, great. Yeah, go ahead, Tina, if you wanted to add something.
We're actively exploring it because there's so many use cases where it really could be helpful, right? And again, not to replace people individually, but like to meet the needs where we're not currently able to meet them. Like there's just too much demand, like translation of documents for one thing, right? Like the volume is just too much, and then they're getting messages through MyChart and other things, and it's how do you do that and have a quick response time, and and to improve the communication and the tools that are available. So we are actively exploring it. The downside is the accuracy isn't there right now, right? But it's coming. We're thinking, and so we're trying. I think that we have to partner and recognize that this is technology that is coming down the pike, and we figure out ways to work with it, and where it can meet those use cases where there really is a need, and it could potentially help us do it a lot faster. And so that's our take on it. Talk to text as well.
Yeah, for sure. I am actually going to exercise the prerogative of the chair, or the man, I can't think of the word, of the host, or whatever you want to call it. And just mention to everyone who is on this webinar today that there is an effort underway within the language industry, language services industry. It's pulling in representatives from hospitals, from all sorts of different public institutions, as well as educational institutions, interpreter associations, etc. It is called the Safe AI in Interpreting Task Force. It does have a website, safeaitf.org, and it is seeking to be able to provide accurate information about what the expectations are, what we can expect necessarily from AI, and how can we introduce AI to be able to handle a large volume as a tool in the toolbox, but do so in a safe way, particularly when you're dealing with things like healthcare and also the justice system, right? But there are a lot of other areas there. So again, that is safeaitf.org. I encourage you to check it out. There's going to be a lot more coming in that area, because we know how important it is to provide communication. And we also know that technology isn't going to disappear, but we need to make sure that it is used in a safe and responsible way. So, all right, we've got one other question, I think, before we are going to wrap things up. This also comes from someone who is participating in our call today, Marifer Sager. She is asking, what do you think is the next thing in the world of language access? What's coming down the pike? maybe that's AI. I don't know. But
Yeah.
what do you
That
think?
was my response. I think it's going to be AI linked to everything. For LSPs, we have to explore AI in all circumstances. But then when I look at interpretation, as Ligia was saying, there are just too many things, too many points that are not going to be easily replaced by a robot, like we want to call it. But it will come, and I think we have to make sure that we're able to partner with AI in order to make everything successful.
Okay.
All right, Ligia,
I
any other
agree.
thoughts?
I agree. And I will say that one thing and that I do hope that would be like the next thing besides AI is a centralization of qualifications for interpreters, because that's an issue we have here in Louisiana.
Oh,
where
that's
it's a
great.
little behind
Wow.
compared to the rest of or most of the other states that have language access programs. So that's another thing that I would love to see. I would love to see the interpreters to be treated as professionals, because it is a profession, and for this to be more like official, more centralized, everyone have the same qualifications, et cetera, et cetera.
It's coming, Ligia. Just know
I
that
hope
it's
so.
coming, and it's a career, at least on the East Coast where I'm located. It's a career in different universities. Trainings are very well recognized. What we've seen is that interpreters are being more respected, and we want to see a lot more of that by LSPs, of course, and also by our customers. And again, like Tina said, it was a curse and a blessing having COVID. Clients are now understanding how important communication is, how important interpreting is, the great training that we bring to the table, and I know it's going to continue coming.
All right, and Tina, anything you would add as we wrap
Sorry,
up?
I always have something to add. I'm so sorry. But one other thing to add to the comments that these lovely ladies mentioned is, I would say, the integration with medical records. So being a clinician by background, it's always just top of mind, because I know if we don't make it easy for our healthcare workers to access these tools and to document it, because documentation of this stuff is so critical. I know that these kinds of things are coming down the pike, and in an effort to improve the workflows and the processes, and thereby improve the access and the utilization of the interpreters.
Great. Well, Ligia Gutierrez, Tina Tolson, Catherine Adames, thank you so much for sharing with us. As we wrap up, before you go, folks, I am going to ask that we run our second poll. This is a really short poll to help us improve the content that you get through these amazing webinars. And so before you go, just 3 short questions. Please, if you'll take a moment to fill that out as we wrap up and I provide you with some additional important information, we would be so grateful. So as we wrap up this first roundtable in the series, I want to thank our panelists yet again. Thank you, ladies. Your insight was amazing, and a lot of great information and takeaways here, I think, for everyone that was attending. And I also want to thank our attendees for your interest and for those questions that came, right? This has really been an enlightening hour for me, and I hope that our participants, I hope you share that same sentiment. But before we go, just allow me to announce our next roundtable that will take place in October. It will take place on October 24th. And the subject of the next roundtable is going to be providing language access to patients with disabilities or unique communication needs. So this is a really specialized one, but it's extremely important, something that cuts across all of the different areas where interpreters are used. And so mark your calendars, October 24th. There'll be more information coming out in the different social media channels on LinkedIn, and you'll be able to register, and we hope that you can join us as well. So it will be followed by 2 more roundtables, one in November and one in December, and even more as we go into the new year. So stay tuned and watch out for other webinars and events that are going to be run regularly by Effectif. And if you're interested in my language and technology work, be sure to check out my website at whataboutlanguage.com. Thanks, everyone. Have a wonderful rest of your day, wherever you may be. And thank you so much for joining us. We really appreciate your time. Ladies, take care. And I hope we get to cross paths again sometime in the future.
Absolutely.
Yes.
Thank you.
Thank
Take
you.
care, everyone. Bye-bye.
Bye-bye.